pleasure for me to give this talk on the pelvic congestion syndrome. Thank you very much for the invitation, and it's a really big honor and pleasure for me to give this talk at your meeting of the Vietnamese Congress of Interventional Radiology. Unfortunately, this is just an online meeting, but hopefully in the next years it will be possible to come to your meeting in person. So the pelvic congestion syndrome, this is a difficult diagnosis. The problem is women don't feel it exactly, but even the clinicians do not feel it exactly. The ultrasound may be inconclusive and unspecific. Even the laparoscopy might be unclear or might be normal. And the CT and MR shows in many women the presence of a pelvic congestion syndrome, the enlarged pelvic veins and the enlarged ovarian vein, but it's in different cases not reported, or in many cases it's reported and it's just ignored. The problem is that even many gynecologists ignore the presence of pelvic congestion syndrome, and most other clinicians did not even hear about it. And in my specific case, I'm working at the Medical University of Vienna and also in different private hospitals. Most patients do not come via referring physicians. Most of them come via my webpage, florianwolf.at. What about the clinical symptoms of the pelvic congestion syndrome? These patients have pain lasting at least 3 to 6 months, pelvic pain, and the pain is unspecific. It's in many cases it's unilateral, sometimes it's also bilaterally, or it's moving from one side to the other. It might exacerbate during or before the menses, and it might be stronger in or after long time standing position during walking, lifting, and other changes. The pain is worse during and after coitus. This is in most patients the case, and it might worsen during and even after pregnancy. The symptoms mostly are most severe at the end of the day and diminish with supine positioning, and it can take several hours to subside. What you also see in many patients, but you sometimes forget about it, it can be related to the presence or history of vulvovaginal, gluteal, perineal, or lower limb varices. And what is very important, 15% of all gynecologist visits are because of pelvic pain. And of these 15% of all patients, 30% have a pelvic congestion syndrome. So you can see that this is definitely heavily underreported when you think about your numbers of PCS patients. Why is it often of the left side? There might be a combination with an entrapment of the left renal vein, the so-called Nutcracker Syndrome. And of these patients, only 5.5 have symptoms with pelvic congestion syndrome. In many women, you can see this entrapment of the left renal vein. For the diagnosis, in most cases, the first method is the ultrasound, the transvaginal ultrasound, or even the transabdominal ultrasound. You can see enlarged periuterine veins with a diameter of more than 5 millimeters. You might see the reflux in ovarian veins. You might see that the ovarian vein is larger than 8 millimeters, and you can very often see the tortuous pelvic veins, and you will see a slow blood flow of 3 centimeters per second or less. The MRI is also a method that is very often used. You can see dilated periuterine veins. You can see it here, for example, and you can even see the enlarged ovarian vein in this very nice MIP reconstruction. What I like most for the diagnosis is a CT. In many cases, it's an incidental finding in CT examinations because of abdominal pain and different other types of diagnostic procedures were done before, and at the end, patient sent to CT, and in the report, the patient can read about the pelvic congestion syndrome. Many of these patients where you can see this are asymptomatic, but patients that are symptomatic very often go to Dr. Google and look for the pelvic congestion syndrome because of this strange term, and they very quickly find out about the presence of a pelvic congestion syndrome, return to their gynecologist. There it is often ignored, and in many cases then they directly contact the doctor that is a little bit specialized to this type of syndrome. This is a patient showing an arterial and venous phase. You can see in the arterial phase very early good filling of the left ovarian vein, of the heavily enlarged ovarian vein. It's definitely insufficient because the blood flows down, and this could be not the case if the blood would come from the pelvic region. And here you can see the venous series. You also see the enlarged ovarian vein going all the way down to the pelvis, and there you can see the enlarged periuterine veins. So what about the embolization technique? You can use a transfemoral or a transjugular access. I normally use a Sidewinder 1, in rare cases a Sidewinder 2 catheter. So I normally do it via a transfemoral approach. I bring the catheter to the left renal vein and I do an angiography. In the angiography, you can see the reflux, and if the reflux is there, this is diagnostic for the pelvic congestion syndrome. I do the embolization using a microcatheter and the 014 wire. And what is important that you choose a microcatheter that is compatible with your coils. For example, the Boston coils combined with a 021 microcatheter, and the Penumbra coils, for example, you have to combine the 024 or even 027 inch microcatheter. I do the embolization of the left ovarian vein using the sandwich technique. In most cases, I start with coils, followed by foam, followed by coils, followed by foam and coils. As a foam, I use a doxycycline 2 or 3%. I mix it with air or CO2. And for the coils, I use in most cases the Boston IDC coils or the Penumbra Ruby coils. Alternatively, you even can use glue or plugs. Different centers use different techniques. At the end, the aim is to occlude the ovarian vein, and this is possible with all the different devices that we have for occluding a vessel. Optionally, you also should do an angiography of the right ovarian vein. I do this in all cases, even if in CT the ovarian vein on the right side is not enlarged. And optionally, you also should do an angiography of the internal iliac veins. I will show you a case afterwards. So this is the first case. It's a 45-year-old female patient with a pelvic congestion syndrome since years. You can see here the coronal reformations. This is this heavily enlarged ovarian vein and the enlarged periuterine veins. In these cases, I did an embolization using 8 coils combined with foam and doxycycline 3%. You very nicely can see here when I inject my contrast media in the left renal vein, you have the strong outflow via the left ovarian vein and this heavily enlarged periuterine veins in the pelvis region. This is after placing some coils there in the ovarian vein. There is still a flow through the second branch of the distal ovarian vein, but at the end that was successful. You can see here that there is no more flow. What is very important to occlude all the different branches of the ovarian vein and to, if possible, occlude the whole ovarian vein all the way up to the renal vein, because if you do not do so, the possibility of recurrence is high. This is the final result, doing an angiography via the left renal vein again, and you can see that there is no more outflow via the ovarian vein. It's definitely occluded, and it will stay occluded. So a second case, it's a 33-year-old woman with pelvic pain since 2 years. You can see here is a Cobra catheter, the left renal vein and the left ovarian vein. Again, microcatheter there, microcoils in place and placement of different coils and foam in the left ovarian vein. Case number 3 is a 48-year-old patient with chronic pelvic pain since 3 years. You can see here again this outflow via the left internal and left common iliac vein. Obviously, in this case, also Nutcracker syndrome is present. And again, coil placement, foam placement at the end, successful occlusion of the left ovarian vein, and this is a collateral going to the inferior cable vein. This is good to preserve in order to have an outflow for the left kidney. Complications are really definitely rare. You might have some case of post-embolization syndrome. In the literature, this is relatively common. In my own patients, I have never seen this. There might be a coil migration. I also never experienced this in my patients. There might be a venous perforation. There might be pain. This is not so uncommon that in a few days after the procedure, the patients reported there was some pain in the pelvic region. There might be a hematoma in the groin, and there might be a thrombosis of the renal vein. At the end, the complication rate is really very, very low, even in literature. The technical success is definitely high. If there is an enlarged ovarian vein, an embolization is possible in most cases. So in the literature, the technical success rate is up to 100%. The clinical success rate is also high. Symptom improvement you will find in 80 to 83% of the patients. There is a group of patients where there is no change of the symptoms, and in a very small group of your patients there will be a worsening of the symptoms, but this is definitely very, very rare. In most patients there will be a definitely symptom improvement, or at least as a partly improvement of the symptoms. Post-procedure, I do this procedure in most cases as an outpatient procedure. The patient have to stay in bed for about 2 hours, then they leave the hospital. The pain, as I said before, is possible for 24 to 48 hours, and they do a clinical control after 6 weeks combined with an ultrasound. But the most important thing is the clinical success for your patients. What about the data for pelvic congestion syndrome embolization? To be honest, the data is not very good. There is no randomized controlled trial, for example, comparing different embolization techniques and so on, but you find different case series. This is a case series published in CVIR 2013 with 202 patients with chronic pelvic pain. Again, high technical success rate and even a very high clinical success rate with a complete disappearance of the symptoms in 33 patients and the improvement of the symptoms in all the other patients. Another large group of patients in this study published in GVIR with 131 patients. They did a combination of sclerosants with coil embolization and also had a very good long-term improvement. What is important to not forget about the iliac veins. This is, for example, a patient 32 years old. I did the embolization of the left and right ovarian vein, and after this embolization there was no more pelvic pain, but there were still varices in the region of the vulva and the proximal upper thigh. So the patient came to me 1 year later and she said she's doing definitely fine. Nevertheless, she wants to get rid of this varices. And I did an angiography of both internal iliac veins as well as the femoral veins, and I found these varices coming from an insufficient pelvic vein. You can see here the filling of these varices in the region of the vulva and the right proximal thigh. So I did an embolization of these veins there with coils, and at the end they were not perfused anymore. Next point is the Nutcracker Syndrome. So this is a compression of the left renal vein by the aorta and the SMA, and this is very often combined with the pelvic congestion syndrome. You have a renal vascular compression in this case, and the typical symptoms might be hematuria, proteinuria, orthostatic hypotension, pain, or even renal dysfunction. But the symptoms are very unspecific, and when you have a long-standing venous compression, there might be a collateral drainage pathway through the gonadal and pelvic veins, and this is the typical symptom and syndrome overlap with the pelvic congestion syndrome. So the question is now stenting, yes or no? And there are some rare studies in the literature. This is a case series of 75 patients with stenting of the left renal vein and a 55 months follow-up. there was a high rate of stent migration of up to 6.7%, either to the inferior cable vein or the right heart, or retrograde to the renal hilum. You do not want to have this for your patients. These are very often young patients, and you don't want to have any of these complications in only a single patient. There was no significant variances in stent sizing or positioning to explain the cause of migration. Another study with 18 cases of left renal vein stenting, they had a primary patency of 85%. At 2 years, this is not very high because, again, these are often young patients and do not want to have a single stent occlusion in this group of patients. So 5 cases were performed for stenosis after left renal vein transposition, surgical transposition. 3 remained symptomatic despite stenting of this stenosis after the transposition. So at the end, I definitely think that stent implantation in this Nutcracker syndrome is not a good idea. This is a patient from my case series. It's a morphologically nutcracker with consecutive pelvic congestion syndrome. You can see very nicely here injecting contrast media in the left renal vein, showing the full outflow of the blood to the pelvic veins and to the left internal iliac vein. And you can also see the collaterals there because of the compressed left renal vein. So I did in this case an embolization of the left ovarian vein, and you might ask yourself now what happens to the kidney if you include the outflow via the ovarian vein. And I can tell you I did this in many of my patients, and nothing happened in all of these patients. The patients got rid of their pelvic congestion syndromes, but did not develop any symptoms of the kidneys. So no renal symptoms before and after embolization, no more clinical signs of pelvic congestion syndrome. So I conclude that according to the literature and according to my opinion, stenting of the compressed left renal vein is no option. There is a very high rate of stent migration and the stent fracture is possible. You often have young patients and you do not want to have a single complication in this group of patients. This is another nutcracker case of my series. It's a very young 20-year-old female patient with pelvic congestion syndrome, and she had this in combination with a recurrent urinary tract infection. She had a compressed left renal vein and highly insufficient left ovarian vein and massive dilated periuterine veins. You can see it here. This is the angiography. You can see here injection of the contrast media in the left renal vein and the full outflow via the ovarian vein. You can see it here now in the pelvis, this enlarged periuterine vein and the outflow via the right internal iliac vein. Lots of coils were needed to stop the flow. At the end, at this stage, it's not allowed to put foam in there because the foam will go to the left internal iliac vein and even to the lung. So at the end, I placed more coils, and at the end, I was successful also putting some foam there. And you can see here that the vein is occluded. And this is an injection again via the left renal vein. There is no more outflow via the originally insufficient left ovarian vein. In this case, because the patient was young, I did not place the coils all the way up to the left renal vein because I also wanted to keep these collaterals for the kidney if the blood of the kidney looks for its way to the cable vein. So I come to my conclusion. The pelvic congestion syndrome definitely is underdiagnosed and underreported. MRI and CT, in my opinion, is very helpful for the diagnosis and treatment planning. Embolization is the method of choice. There are different embolization agents available. I use coils and foam using the sandwich technique. This is also in literature used in most cases. Embolization shows very low complication rates, show a very high technical success rate, and a very good clinical success rate. In my opinion, in patients where you have Nutcracker syndrome, you should not place a stent because of very high complication rates. So I'm at the end of the presentation, and I hope you have some questions for me, and I thank you very much to invite me again, and I hope you enjoy the rest of the Congress. Thank you very much.